started. So I would like to welcome you to this session on global health diplomacy as an aspect of international soft power. My name is Francis Fukuyama. I'm a senior fellow at the Freeman Spogli Institute for International Studies at Stanford University. I'm the director of the FSI Center on Democracy, Development, and the Rule of Law. And as you might guess, I have nothing to do with health. I'm a political scientist. My background is in both foreign policy, international relations, but also in domestic governance systems. And actually, over the last few years, I've really taken a great interest in the development of governance institutions, including those that deal with the provision of health services. So I don't know how it happened, but I'm delighted that the organizers of this conference decided to ask me to chair this panel, because I think there's actually a lot of very interesting cross-disciplinary work that can be, that all of us can take part in. So I am not going to do a detailed introduction of the three panelists. We have an excellent group of people to talk about this subject, all of whom are deeply involved both in global health, but also in the interface with political systems, and have dealt with the question of how diplomacy and the international space all interact. So we will go in the following order, and I will let them both introduce themselves and to introduce a little bit about their programs. And then at the end of that, I want to have a discussion among the panelists to solicit their views on a variety of different topics. So let me begin with Yan Guo from China, who's a professor of public health and vice president of the Peking University Health Science Center. So, Yan, go ahead.
You have introduce myself. Yes. Okay. Good afternoon. I was vice president, no more. Good afternoon, everyone. It's nice to be here. Thanks for invitation. And my name is Yan Guo. I'm from Peking University School of Public Health. My background is, I'm not a diplomatic person. My background is public health by training. Currently, my field is health policy and administration. Global health is our new department. I'm a joint department in Department of Health Policy and the Department of Global Health. Very nice to see you all.
All right, our second speaker will be Mariam Jacobs. Mariam Jacobs is Emeritus Professor of Pediatrics and Child Health and retired Dean of the Faculty of Health Sciences at the University of Cape Town in South Africa. So Mariam, do you want to say a few words?
Yeah, thank you for inviting me to be here. Just a disclaimer, I'm actually not at the interface of health and politics at all, but I am a South African, and I'm sure you know what's happening in our country right now. I also, my experience in the global health environment comes from having served, and I still work with some WHO committees, but I also on the other end serve on a board of a PEPFAR-funded NGO in South Africa. So I speak from that perspective, but I certainly am no expert on global health diplomacy.
Thank you very much, Miriam. And our final panelist is Ambassador Eric Goosby, who's returned to UCSF as a professor of medicine in the Global Health Sciences program, but before that, he had been appointed to be the Ambassador at Large and U.S. Global AIDS Coordinator, which oversaw PEPFARs, and prior to that, in a number of other important positions in global health. So Eric?
Well, thank you, Frank. It's a real pleasure to have an opportunity to bring this issue in front of this meeting. I think much of my work in both the PEPFAR programs and in the domestic work in the United States, in a program that was like PEPFAR for the United States called the Ryan White Care Act, many of the issues that come forward as you move from a domestic one-country discussion into multiple country or bilateral discussions requires that a diplomatic conduit be nurtured and sustained, and that oftentimes public health thinking does not incorporate that diplomatic agenda. And so I'm happy to participate in this discussion with you.
Okay, very good. Now, Yang Guo, I understand you actually have a slide presentation, so maybe we should move to that and you can do a more formal presentation of some of your work. If we could get that up on the... Yes, okay, good.
I can stand here because, global health diplomacy, actually global health is a very brand new word in China. So global health diplomacy even new than that. So I would like to take a few minutes to talk about global health diplomacy in China. First look at the progress of diplomacy in China. I think global health diplomacy is a part of global diplomacy or in China. To look at, we look at in 1950s when People's Republic of China established, everything learned from Soviet Union. So at that time, we introduced public health. So at that time, the model of public health, we copy the model from Soviet Union. In 1970s, in our diplomatic policy, we traveled the Asia, Africa, and the Latin American. At that time, we sent the medical team to Africa and Latin America and China, Asia as well. It started from 1963. And in the 70s, we had a chance, people of the Republic of China, we had a chance to enter the UN families in 1971, and then next year we went to we joined the WHO. But in 1980 to 1990, when China opened the world, the diplomacy serves modernization society. So in health side, we are more close to developed countries because we want to learn the modern society. But we enter into the new year after the 2000. I think there are two important events. One is MDG. So health diplomacy transfer to the builders of global health systems. And then the last year when President Xi Jinping proposed Belt and Road, the diplomatic policy, and then we more emphasize health cooperation in Asia and Africa. So that's for the forms of health cooperation in China. I can take example from Africa. We started from 1963, we sent a medical team, and medicines 1970s, built hospital. 2000, we emphasized human resources, and started from 2006, there is a big malaria programs, population-based malaria programs. In 2014, we provided emergency health aid towards Ebola. I should say this year, President Xi Jinping proposed the 600 project on 6 components, including the health. So health is a part of diplomatic policy, national diplomatic policy. That's medical team. I don't want to read it. I leave this PowerPoint to you. The medical team and the building health facility and the provided medical equipment and medicines, and also human resources and for anti-malarial campaign, we provide medical services, training program, equipment, and population-based anti-malaria intervention product. And what's the impact? I think that there are 4 impacts. First one, provide direct medical assistance to the poor areas, especially for remote areas. And the second one, contribute to strengthening health systems. Third one, disseminate knowledge on traditional Chinese medicine. The fourth one is promote the China-Africa cooperation. So that's a principle have been reaffirmed under the China-Africa policy in 2006, which emphasized the principle of the cooperation. That's sincerity, friendship, and equality, and the mutual benefit, reciprocity, and common prosperity, mutual support, and close cooperation, and learning from each other, and seeking common development. That's our foreign policy. In our global health, we also follow those 8 principles. So this is a China Emergency Health Aid for Ebola in West Africa, and that's amount of money we put towards Ebola, against Ebola. That's beyond that. There's a cross-border cooperation with the neighborhood on the one belt, the Belt and the Road. That's a different formats. Thank you for your attention. Thank you.
Okay, thank you very much. Okay, so I believe neither of the other 2 panelists has a formal presentation. So I think what we'll do is move to a panel discussion. So the reason I think that the question of health diplomacy is important is because there is inevitably a political side to global health. This is not simply a technocratic practice, and it comes up in a number of respects. First of all, it really is about power. You can't implement health programs without resources. You can't do them on the ground without having support, political support from governments. And wherever you have the use of power, you have conflict. You have different perceptions of what the problem is, different priorities, and in the international domain, this becomes involved in all of the international conflicts, differences of perspective, and concrete differences of perspective. So I think it's actually quite appropriate that we started with a description of China's evolving health programs. China is now, as you know, the 2nd largest economy in the world. It has moved from feeling like a victimized taker of international policies to a country that is increasingly beginning to shape the international system, sometimes in ways that make other countries in the international system not so comfortable. But there are many other aspects in which I think these different country perspectives play out on the ground in terms of the way that programs are administered, in attitudes towards governance, and attitudes towards things like human rights, democracy, other kinds of value questions that are contested in the international space. As a political scientist, I think this is why we need institutions. Institutions are basically rules that govern the way that both people at a national level interact and the way that countries interact at an international level. So I'm hoping the panel will get to all of these questions. So let's just begin with a really basic issue, which has to do with the word diplomacy that's in the title of this panel. Does it make sense to talk about health diplomacy and to see it in a international relations framework? So I think maybe with Ambassador Goolsbee, since you actually headed a unit at the State Department that was, did it have the words health diplomacy in the title? Yes, okay, so obviously, this is something that you've been intimately involved in, so maybe you could give us your perspective on that.
Sure, thank you. The State Department office was started by Secretary Clinton as she began to end her term of office. Over the course of her 4 years, she, through much of the work that came through global health programs, saw the utility that was afforded diplomatic discussion in countries where there were other issues that were on the table. Having had a decade or more of global health investment in that population allowed the diplomatic discussion with the ambassador to country leadership to go and probe in areas that may not have found a receptive audience had that 10-year plus investment not been present, and was frequently in a position in those countries where that investment continued to push countries more aggressively, if I could use that word, around human rights issues and issues around minority, underrepresented, or discriminated against agendas that came up. In the sub-Saharan African countries, the issue around gay, lesbian lifestyles became a major issue coming not out of the President, Prime Minister, Minister, Cabinet level arena, but out of the legislative part of the government. And in 3 instances, we were able, over the course of multiple discussions with the President and in many instances with the Minister of Finance, we're able to express our concern and put a expectation in place that this was unacceptable for the following reasons: from a public health perspective, targeting and creating barriers to access for this population moved the behavior underground, and that individual is less likely or not likely to reveal themselves to the medical delivery system for fear that it would be revealing themselves to authorities and to the negative sentiment. In Uganda, in Rwanda, in Kenya, those discussions occurred. It actually included discussions with the White House and with the President on numerous occasions. And we're able often, again, behind the scenes, to impact how countries positioned themselves with that particular issue, or if nothing else, put on the table the fact that the United States was open to further dialogue and to better understand the disincentive for accessing and retaining patients in care was of real concern to the public health programs that the United States continued to invest in. So I think that it was perceived as something every ambassador in the United States should have as a tool. The understanding of the demographics and the burden of disease in each country became part of the briefing materials that went to our ambassador staffs. And a health lead, either in the form of USAID, most often, or Center for Disease Control, or the PEPFAR program lead in country. One person was identified as the conduit through which the ambassador would be briefed. So they had a fairly deep understanding of the diseases that were in the country they were ambassador in, and then what were the public health multilateral resources that were available to respond to those that were outside of the country. Our ambassadors often took, with that knowledge on their own, active role in bringing those external resources into country and convening discussions that allowed those resources to be accessed by country systems of care. I also think that it allowed the soft power agenda of the administration to have a programmatic reflection that allowed for a more, it prioritized that soft power agenda in each country to be actually a topic that was discussed, and when ambassadors would come back to Washington, they would, on a routine basis, go to their own regional office in the State Department and also the PEPFAR program for a debriefing. And it became, with the Office of Global Health Diplomacy, part of the routine of the diplomatic corps in those countries that carried a PEPFAR program. So that was the idea.
Okay, so I'm going to get to Dr. Guo and ask her for her perspective on that kind of approach, because China has a very different attitude towards what it sometimes regards as interference in the domestic practices of countries. So we'll get to that question, but in the meantime, I'd like to go to Dr. Jacobs. So South Africa is actually quite an important player in sub-Saharan Africa as a whole. It projects its influence over the whole continent, but it's also in many ways a recipient of policies made elsewhere, especially in places like Washington. So I'm wondering if you might react to what Ambassador Goolsbee has said, or from the perspective of somebody that deals with these big, powerful international players, what your views on this are.
Sure. So I think that PEPFAR has been an incredible intervention in South Africa. There can be no doubt about the extent of the funding that has enabled us to kind of to respond to the terrible scourge of HIV and AIDS. But it does come with challenges. And the challenges are in the scale of things. So at the moment, the PEPFAR funding complements funding coming from the state, from the fiscus, and is able to address aspects of the epidemic that we can't necessarily afford with our national resources. But the challenge has been not so much in terms of our appreciation for PEPFAR, but rather the burden that this PEPFAR funding puts on both the state and NGOs. So the requirements for, first of all, and let me not just talk about PEPFAR, because I think we look at CDC and USAID as well. So first of all, in the kind of tender process where there are calls for proposals, some of the CDC-funded proposals, the call goes out internationally. So whoever can write a phenomenal grant proposal, whether they are South African, African or not, can then compete. And I spoke to a couple of the NGOs before I came here, and they said these guys write beautiful proposals, but they have no idea of the implementation on the ground. So that creates a level of tension. The second is that the administrative requirements are huge. So all these programs have this performance-based financing, information systems that sometimes don't cohere with the information systems of the country, and priorities that may dislodge our national priorities. So we've had to deal with that in very difficult circumstances and in different ways. And in the midst of all of this, we had a Minister of Health who didn't believe in the science of HIV and AIDS. And it was very interesting because her predecessor, who's now the Secretary General of the African Union, and her Director General, so the Minister of Health and the Director General of Health both moved to the Department of Foreign Affairs. So it became a very interesting time for them to handle the tension between not only the minister, but also a president who was an AIDS denialist. And in that environment, diplomacy was, whether it was national and very often very local diplomacy that had to come into play in managing that situation. So I will leave it there. I've got some more things to say about the challenges and the opportunities. Okay. But I would ask, though, that at some point we define this thing called global health diplomacy, because it has different meanings for different people. It has different axes. So what is global? Is it just the North and the South? I'd like us to have a conversation about that at some point.
Okay, well, we'll get to that. But I assume from the standpoint of a medical professional like yourself in South Africa in the days of Thabo Mbeki, it was actually good to have this international framework where it could bolster the case for taking HIV/AIDS seriously, and that entered into the domestic discussion.
Yeah, and particularly having the funding. Mm-hmm. That was incredible. I think in the end, the South African scientists banded together with international colleagues and kind of turned it around. But, yeah.
Okay. All right, so as I said, Yang Guo, I want to get to this question of China's perspective to the kind of health diplomacy that Ambassador Goolsbee described. China has taken a principled stand that, well, first of all, it doesn't believe that there are such things as universal human rights. It believes that sovereignty is really the guiding principle, that China does not intend to interfere in the domestic policies of countries that it works with, but really it's simply supposed to be something for mutual benefit as defined by the local country. And so do you see that there's an alternative Chinese approach to health diplomacy from the sort of thing that America and some European countries practice?
It's a hard question to be answered by myself because I'm not, as I said, I'm not I don't have any background of diplomacy.
Well, just from your work, though,
yes,
I mean, you can talk about.
I think the one side, China would like to learn from U.S. and European, from developed countries, and most on the technique, most on the project-based, but on the philosophy or diplomatic philosophy. In my understanding, so far, I don't think we're ready to learn global health diplomacy. We want to learn global health diplomacy, but we just start getting to know what about global health diplomacy, because I can give the example. The first step, we translate some book from the global health diplomacy from the U.S. and also from Geneva Institute. They published. So we hold the series of executive training course on global health diplomacy, just to give some concept, but not real implemented as U.S. and Europe.
Okay.
Thank you.
Well, let's go to the question that Dr. Jacobs raised. What is global health diplomacy, or how do we define it? Because there's obviously a lot of different levels on the level of international organizations, at a national level in terms of bilateral relations. So, Ambassador Goolsbee, I mean, how do you define it? How does the United States government define it?
I think that it is defined in a very broad way for the U.S. government. identified not only the kind of science of the epidemiology of the disease process, but also tried to understand with specifics the response to that disease in each country, and then seeing the U.S. involvement in that country as being a means through which resources could be, needs could be defined and resources could be identified, and then through U.S. Supported efforts in partnership with the partner country, deliver them. So actually follow it all the way from identification to initiation of a response. And commit with the country over the long haul that U.S. support would continue. Not to pay for it necessarily, but to help the country in a partnership to understand and respond to it. At times, it may take the form of resources or the scramble to identify resources, but not necessarily. And it was really a means through which that relationship between the bilateral relationship was thought to be strengthened. It also has an ethical component to it that is worth mentioning. Unlike a road or a building, your ability to withdraw support from a health program is limited or even preempted. You cannot withdraw the ethics of withdrawal from a country without a transition plan that accommodates the people, the patient population that you have already assumed responsibility for in part, cannot be abandoned. And especially in programs like PEPFAR, where there was often a relationship of the U.S. federal government to the partner country government, but often did not have a formal, did not use the public system to put the clinic or hospital in place, but used a multinational NGO or a private sector, or even in many cases would go in and rent a site and transform it into a clinic or service site. That put the United States in a direct relationship with the people who needed and depended on those services. And we, as a U.S. government, could not just suddenly stop that activity without abandoning that population. So this was a large discussion in the U.S. government initially in 2009. Secretary Clinton and President Obama very specifically wanted this to be addressed, and the agreement was made that for humanitarian health-related interventions, that there would be a transparent process before any withdrawal of resources occurred, and for the most part, that process precluded withdrawal. And in the time that I was in government, that really never hit the fan, even though we thought it might. We realized that our relationship had to be honored with the people who were actually using those services. So I think it is a fair question to think about what we mean by global health diplomacy, but that at least is one version of it.
Okay, Dr. Jacobs, do you have a reaction to that? Or?
Yeah, I actually have a reaction to the whole concept of global health. So, because I think that the diplomacy there depends on how you define global health. And it's tended to be a discipline, a means of addressing burden of disease. And so many of the interventions, many of the examples are disease-based examples, whether it's PEPFAR, rollback malaria, or whatever else it is. But I would like to think that global health goes beyond that, and that we have to think about a mechanism for building health systems. Does that fall into global health? A mechanism for advancing this global intent for universal health coverage and hopefully universal access to quality health care. And most significantly, is global health a means for addressing the inequities in healthcare, in health status, in health systems, and may I say it, in health institutions like universities? So when one is talking about global health diplomacy, there are, I guess, the formal arrangements between states that lead to treaties, like the framework for tobacco. There are the less formal arrangements, like a US program like PEPFAR or USAID and CDC. And then there are the informal global arrangements, which relate to big funders like Gates and Slim foundations, and also funders like Wellcome and the NIH and research collaborations. So I think I would hope that our discussion today looks at diplomacy in those areas as well, and not just takes a look at global health as something that the North does for the South and the burden of disease, but rather something that encompasses all of us in an effort to address the very fundamental issues of health inequities.
Now, of course, if you define global health in terms of something like universal access to health care, then all of a sudden the league tables and global rankings change a lot, and the United States falls quite considerably.
And India has just developed their own, reported today.
And do you think that there are actually institutions, I mean, you know, those get into these very tricky political issues of budgetary allocations. You know, that's certainly the issue surrounding the ACA in this country. Do you think that actually the international community can be helpfully involved in those sorts of discussions, or how, or maybe not, whether should it be? I think we all agree it probably should, but you know, what are some effective ways of doing that?
Yeah, so on Wednesday and Thursday of last week, there was a very interesting meeting in Nairobi where the Eastern, Central, and Southern African health communities got together. Academic institutions, the state civil society, social movements got together at the end of a program, a 3-year program, where they looked at Africa's response to global health diplomacy and what kinds of things should be done. And one of the issues that emerged from a 3-year research project that they did with an institution, a university in the UK, was the issue of space in the global discourse for the voices from the regions to be heard, space in the planning, space in the thinking about issues like performance-based financing, and not just space, but the opportunity to have voices heard and taken seriously. So the one example that they cite was the kind of African bloc at WHO that pushed for the issues around migration of health personnel, the issues around access to essential medicines, and so on. So I think there is a new way, perhaps, of looking at global health diplomacy in a somewhat different way from which a single country might want to take the issue forward.
Okay, very good. So, Dr. Guo.
Okay, thank you. I think that there are two very important keywords. One is global health, another is global health diplomacy. For global health, in my understanding, there might be two circles. One circle is global health development. Another one is global health security, and they cross each other. And the global health governance cross those two circles. I think global health diplomacy is a very important part of global health governance. That's my personal understanding. And I would like to, another point I would like to say, based on the Chinese model, I think that to implement global health diplomacy better, there are two very important group population. One is public health, our health. Another one is diplomatic people. Because, you know, for example, for health aid or health cooperation, the need or demand proposed by embassy. But the embassy, the people working in the embassy, they don't understand the health or public health very well. So they couldn't give the very good diagnosis or digestion. So they transfer the information, and public health, Ministry of Public Health, adopt those information. Something it's the people need, and something the note. For example, in this summer, I went to the Comoros to do the evaluation for the malaria control in there. The Chinese government building the very good hospital, and but this hospital far away from the people lived, and there is no power, there is no water, so it couldn't run this one. But when I ask why you select this place, they said, this embassy tell us. I asked embassy why you set up a hospital in that remote areas. There's no population use that one. So the government asked us. So I think the population for implement global health diplomacy better, we need dialogue. We need the diplomat people understand the public health, and the public health people understand the diplomacy. That's my.
So in the Chinese Foreign Service, there's no equivalent of like a health attaché or
no,
doctors
I think
who are,
we would like to, in the future, we would like to learn from traditional donor to build that good systems. Usually, for example, usually the health project proposed by embassy, but sometimes the embassy, there is no health person working at the embassy. So that's a challenge we are facing in the future.
Okay, so I want to shift the discussion a little bit to the question of how does the international community deliver health services in areas of very weak governance? Obviously some of the worst health crises take place in countries with a collapsed government or a very weak government. I mean, you think of the crisis that's been ongoing now for several years in Syria. That may be a problem a little bit beyond the scope of anyone to really solve, but certainly there are many other parts in the world where the international community has stepped in, and one of the perennial questions is, when you are dealing with weak governance, do you simply provide the services directly? Do you bypass that weak government? And if you do that, then are you in some sense displacing or sucking out capacity that really ought to be delivered indigenously? On the other hand, if you wait for those indigenous institutions to be built, a lot of people are going to die. You won't be able to deal with epidemics and the like. So perhaps we could talk a little bit about this issue. So Ambassador, would you like to start us off?
Sure. I think that so the aspect of it you wanted to focus on is...
Well, what's the appropriate approach? I mean, how much intervention and just,
in a failed state.
And not just a failed state, but also, countries that have governments, they're reasonably stable, but they just don't have the capacity to really deliver.
It is a very tough dilemma. There are many governments that fall into the weak but lack the medical infrastructure to do the planning and engage in meaningful implementation, or there's a central will, but as soon as you get to the provincial, district, and village level, that the often unfunded mandate decentralization process that's gone on has not caught up with itself, and the resources to create the capacity at the provincial or district village level is not available. In those instances, what we've done in the HIV/AIDS TB arena is deal with whatever convening the government can do, or civil society. And it means that you are not trying to create parallel systems of care, but in so much as you can tease out both a public sector, such as it is, but match it and amplify it, or just replace it in a parallel attempt with existing community-based organizations that are in and of the country. Faith-based organizations are often freestanding, often very separate from the government, but have a 50-plus year history in country, with a predilection for rural versus urban, for the faith-based facility sites, and put a coalition of interested stakeholders together, ideally including those who depend and need the services, as part of the planning and implementation process. That requires coordinating capability on the ground. We have often used military of the country because they have that infrastructure that extends beyond the capital city, and started with HIV, the rollout for services in those countries that were weak went through the military infrastructure first and then expanded to the general population. And it did do that in each of the countries that we were in. The problem is that the country does not move to scale those types of services for military. So military hospitals and clinics, there may be 4 of them in a country or less. The ability to see and serve patients outside of that catchment area is very limited, nor are those facilities capable of expanding to the volume that often would come in. It worked well in countries that also had their own public health infrastructure, and then between the delivery system of the Ministry of Health with the faith-based and with the military component, you were able to patchwork a capability together. I think that the UN system can often play a bridging role, where they can come in and put a capability on ground for a limited period of time. It is usually apart from civil society and government, and requires a scale-up startup, and when you leave, it requires a dismantling exit strategy. So the net gain is often hard to distinguish once it's pulled out.
But one of the criticisms that's frequently voiced about PEPFAR and the Global Fund and these big interventions is that it's not that they don't collaborate, but they actually suck capacity out of the indigenous institutions, because they generally pay much higher salaries. A lot of doctors and nurses that had been working for the health ministry go to work for international organizations, and then the international fad changes after a few years and the funding is gone, and there's actually less capacity than when you is that a fair criticism? And if so, what do we do about it?
It's a fair criticism. I'll just react quickly to that. We tried to work against that by not kind of doing the brain drain, stealing people. But you often are in situations where there is no other choice. So to tell somebody in a clinic that they shouldn't leave that clinic because there's an opportunity for you to make more money and all the benefits that are afforded the family and everything usually win. The number of times we have trained people who then get taken, I can't count. But I realized it was a difficult discussion to have with that individual because it really was in their best interest to take that higher paying wage and move toward that, even though they had all the reservations that you're talking about. I think the fundamental flaw in this system, it is the corruption of a large pot of money coming in part, but it's also, maybe more so, the lack of a living wage that's present in the public clinic site that individual is employed in. Many of our colleagues in country who are attracted and pulled out with an international NGO would gladly stay in the position they're in if they made enough money to meet their needs, pay their school fees, get their kids' uniforms. It's always those kind of issues that are the ones that cause the exit. So the fundamental, I think, defect is the lack of a living wage.
Dr. Jacobs?
Yeah. So you're spot on, actually, because I think that we've seen with not only with the U.S. Foreign funding, but also with other bilaterals where people are obviously attracted to euros, and the South African rand is sitting at about 15.5 to the dollar at the moment. And so that becomes very attractive. But I just want to return to the question that you asked about fragile states. Mm-hmm. And yesterday in this room, there was an incredibly moving panel of people who spoke to that issue. And one of them was the US head of MSF, who spoke about the challenges of having to deal with those issues. So in my view, there are three phases to addressing that situation. The first phase is obviously the emergency intervention. The emergency intervention in Syria, and also the emergency interventions that were needed in places like Sierra Leone with the Ebola outbreak. But then there needs to be a next step. And the next step is the reconstruction, the setting up of new systems, the setting up of new institutions where global partnerships come into play. And then finally, I think the global partner will have to look at their role where those institutions become sustainable and viable. So this conference is about universities with global health. So I heard this morning about the number of US universities that are expanding across the world and having campuses across the world. And what happened in my institution when I was a dean was one of my very senior professors came to me and said, a US institution has just asked me to come and work for them, and they're going to pay me much more. What must I do? He said, I don't want to go. But obviously, it's the issue that Eric raises. And I have to say that professors at the University of Cape Town can certainly afford to send their children to school. So we then had to give him an additional stipend. But as your institutions start coming into our countries, you're going to be looking for people to work in them. And our people are going to be attracted to the dollar. So I raise that because it's a focus for global health diplomacy that the consortium of universities with global health might want to think about.
Okay, Dr. Guo. So China has obviously had a lot of experience working in very difficult places.
Be honestly, personally, I don't have any experience working with weak government like you said. Chinese government is very strong government as soon as they decided and everybody followed. But for those kind of government, for the strong government, you still need to face a challenge. It's a different challenge. The challenge how to pursue the government collaborate with this project. But I think, in my understanding, I think the government has a different level of the government. If if the central government is weak, maybe the community leaders, you can start from the community and working with them, and from pilot show the success with to the central government. They might agree to do that.
Okay.
Sometimes, in China, China is a unique period. Before that, we had a long history to be recipient country, but in the future, we want to be the donor country to have others. When we were the recipient countries, I think to decentralization, social mobilization, I think it's very important. Another success experience started from pilot and show success to the central government, then transfer from pilot to the national policy.
Okay.
It's our experience.
Okay, we have about a half hour left. I want to open the floor soon to questions. But one issue that we've not talked about so far is the whole multilateral layer of global health. And obviously, that's also an area of contestation in terms of who controls these organizations. There are questions of who runs them, what the division of labor is, whether we have the right setup. So anyone on the panel, would you like to, please?
Yeah, a couple of years ago, we looked at the governance of some of these global health organizations, and it was quite scary, actually, to see the lack of voice from the global south. But in the room next door, I think they are talking about financing global health. And what I haven't heard spoken about is the new Global Health Investment Fund, which is going to bring, and I'm sure people know about that, it's going to bring a new area into play in the whole global health arena, with a social compact between the private sector and some of the donors, and then looking also at the focus on commercially viable interventions. So how does one engage with that kind of initiative, which is beyond the scope and opportunity for global players to get involved?
Would anybody else like to comment on this?
I would just say that the multilateral layer is potentially a harmonizing, equity redistributing agent that could act globally if it positioned itself to do so. I think that it is a need that is unmet or partially met, and I think the global health community should look at itself from the perspective of what's needed and how can we back into taking advantage of existing institutions to create that capability. Countries need to, the donor community and bilateral efforts that come into the country to put services and program on ground should have a strong preference, if not mandate, to go through public systems first, if at all possible, to expand capacity of those systems while they build the new capability, and to look for enhancing and supporting management and oversight that is in and of the institutions that are in and of the country. If that is the approach, you don't have the fragmentation, the dilution, the diversion of people away from that core service complement. But that kind of orchestration requires a convener, and if the country isn't strong enough to be that convener, we're at a real deficit. But that's kind of the model that we need to start talking more about, and looking for ways to support.
Okay, go ahead.
Yeah, so last week I spoke to the convener for South Africa. He is a chartered accountant, a public health physician with probably a PhD or something. He sits in the National Department of Health. And he said that he's probably one of the strongest public health people in the country. And he said, you know how hard it is because we have all this funding coming in from different donors, and we have to meet each one's requirements, which may not be aligned among them, nor aligned with our own requirements. And he said, you know how many people I have to do it? 20 people, and they only do this part-time. So he said, we really appreciate the funding, but our capacity continues to lag behind because we can't keep up with that kind of convening. So it is the ideal way for the country to have a mechanism to coordinate all of this, but it takes a lot of people to do it.
I agree with Marie. I think different organization has their goal and objectives, even for one country. And even for one country, they design their project by themselves. Their lack of dialogue and coordination. So there are a lot of duplicated the activities. And I think it's better to have maybe one UN agency to coordinate based on their expertise and working with the country government closely. I think it's
well, in this respect, global health is no different from any other aspect of development, and inadequate global coordination, too many cooks stirring the pot. Okay, so we will go to our Q&A session. So if you could briefly introduce yourself and ask a question.
Hello, my name is Daniel Leventhal. I'm a pre-medical student at UCLA. My question is dealing with something Dr. Guo mentioned, but I would be honored to hear from all of you. Dr. Guo, to clarify first, you were talking about a lack of understanding of public health on the side of the embassies and vice versa. Are you talking about embassies in China or in general, like in the US and other countries? And furthermore, could you give an example of when a lack of understanding of public health, maybe in an embassy, could be inconvenient or be detrimental to a situation? Like maybe do you think like Brazilian embassies should have a Zika specialist on hand when preparing for the Olympics?
Okay, good question. Yes, that's true. In the embassy, there is no health people working on that. Sometimes when they has decision making, they consult with the MOH, but not always. Not always. Sometimes MOH just follow their demand. So that's a big challenge for us. I think to solve this problem, the Chinese government tried to solve this problem. They proposed in the future, it's better to send the health embassy, health ambassador to each embassy, but it's not easy. They need the diplomatic system reform. That's a challenge we are facing. Thank you. But I would like to add one word. Start from 3 years ago, we developed the training course on global health diplomacy. We executive training course on global health diplomacy. We invited the people from MOH and from Ministry of Foreign Affairs, gave the opportunity to let them dialogue. I think it's just a start. Thank you.
Okay.
Thank you for a very illuminating discussion. My name is Inon Schenker, and I'm on the Faculty of Global Health at Ben Gurion University of the Negev in Israel. One short comment and a question. I think that brain drain, brain gain, and also funding might be considered health economy and less health diplomacy. That's my personal view. And to the question, I think that if global health diplomacy is becoming a discipline, hopefully also a science, then we may want to see some measurements coming up shortly. And I'm curious, Ambassador Guzbi and others, what would be a measurement you could see for the future in trying to equate who has done better? Cuba in its global health diplomacy, having much cheaper oil from Venezuela, for example, or the footprint of its doctors in most of African countries, or China for the same, or the US through PEPFAR? Thank you.
That's an interesting question. I think measurements of global health diplomacy are challenging. We have focused on what outcomes can we identify when we do what I would kind of phrase a management intervention with a country, going into their Ministry of Health, working on sharpening the ability to oversee program, to monitor and evaluate it, to use those information systems, bringing data back for the analysis to inform the next budget and be part of your core strategic planning that goes from year to year, to have feedback loops to go to different service site levels down the food chain. So there's a incentive on part of the system to stay informed. I think that the hard outcomes of drop in number with disease, so incidence drop, mortality drop, are the outcomes that I think would be optimal to be able to put a causal relationship in with. But I can tell you that it's a great question, because that is the dilemma and that's the challenge for global health diplomacy to move into a more academic stream of inquiry. I think also that it's important that we do that, I guess in a word. So I think it's a critical thing to figure out.
Anyone else want to comment?
I think it's a very good question. I think in China, as I mentioned before, there are several forms of the health collaboration in Africa, but we were leak off the evaluation. Just to start from last year, our School of Public Health focused on two evaluations. One is focus one country, to look at in this country those different kind of forms, medical team, hospital, equipment, medicine, or human resources, that they working very well or not, what about problems? That's one country-based evaluation. And another evaluation is disease control-based, that's malaria. In malaria, Chinese government gave also to the different countries in Africa, and also we have medical services, malaria center, and hospitals. We evaluate. We just start. That's a very good question.
Yeah, I take it the organizers of the panel had wanted to have someone from Cuba on the panel, but were not able to get that. It's interesting because I think most of the data on the efficacy of these interventions, it all has to do with, does it control the disease or what are the final outcomes? But I'm not aware of any RCTs or other kinds of studies that actually look at something like value for money, in terms of the efficiency of the operation and, how much of a burden this was on the global health system to provide a certain level of service, even if it wasn't the optimal one. Yeah. So maybe that's something that we need to look at.
Yeah. I think the challenges, the big challenge we are facing is in those countries, the health information systems are very weak. That's a challenge we are facing in measurement.
I think we have, there aren't any that I'm aware of either, but a lot of descriptive pieces, and there are a lot of people thinking about it. I know Paul Wise down in your shop has done some very creative thinking along these lines, and if I put money on where it's going to get across the finish line first, I'd be looking at Paul. But I think it's really important that we figure this out and get those metrics in place. Would love to have causal relationships for a meaningful management intervention. Value for money is an outcome that would be totally legitimate and make sense to look at. But to actually be able to demonstrate that you changed because of that intervention, those outcomes would be a game changer.
But do we need indicators for everything? So I wonder how many sociologists are in the room, because I think there's a place for qualitative measures as well, and perhaps we should be looking to the sociologists, the social anthropologists, the political scientists, who for help in that area, because the more our systems are so overloaded with indicators, SDGs, national, DHI, it just goes on and on. So I take the point from the colleague from Ben Gurion, but I do think we should think a bit laterally about it.
Yeah, well, the political scientists are all into measurement now, so you're not going to get any help there. But maybe a few anthropologists. Yes, please.
Well, we certainly need more sociologists and political scientists in global health. Keith Martin, Executive Director of CUGH and former Canadian Member of Parliament for my sins. Thank you very much on behalf of all of us for being here. I think sometimes, though, we're looking at the symptoms, not the root causes. Nothing kills more people in a quicker way than a venal, corrupt, and terrible government. If you look at the countries where things are some of the worst, the Syrias, the Zimbabwe's, the DRC's, the Sudans of the world, they have what I call the three C's in common: conflict, corruption, and a lack of capacity. And the weak governance and the failed institutions we know are the foundation upon whether we're trying to get a vaccine to people, ARVs to individuals, sanitation. Unless we have that strong, viable governance structure, then things will go sideways very, very quickly. This is a university audience. I want to posit an opportunity for you that I'd like you to consider. What if universities were able to use the powers that they have in terms of the human resources to be able to train and build collaborations between universities, particularly in facilitate relationships between countries in tension or between countries with capabilities and those in low-resource settings, to be able to build their capabilities not only in health, but more importantly, in the public service, in finance, in departments of public works and justice. If we can help to work with countries, if they want it, to be able to build human resources capabilities up in those areas, strengthening public service capabilities, then perhaps that's a bulwark that will enable us to get the ARVs to people who need it, the sanitation to people who require it, the education for kids who need it, and all the other aspects that going into making global health what it is, which I think is really a combination of healthy people and a healthy planet. Thanks.
I agree that the mandate of universities can be expanded, and that there is a place for greater collaborations between universities. But when universities in the global south try to collaborate with one another, there's no funding. So it's very hard for stronger institutions in the global south to collaborate with those in need. So just today in the university global university newsletter, there's an announcement of a new BRICS university, so meaning Brazil, Russia, India, China, and South Africa. And it's going to be interesting to see what happens there. I think there's a real place for trilateral arrangements, to have universities, maybe two universities in a region collaborating with one in another region. So UCSF with the University of Cape Town and the University of Rwanda, that kind of arrangement, so that you get the capacity being shared not only in one direction but right across. So we share our capacity with you guys and with others. So I think there's place, Keith, for looking creatively at how those networks can be built, and I agree with you absolutely.
That's a good suggestion. Actually, we had a plan to set up those kind of a project to involve the university from China, India, Africa, and the United States and the European. We design the training programs and do something together. But I'm so sorry there is a team leader shift from one university to another one. It's disappeared, but it's a very good idea and very suggestion. It was to do that in the future. Thank you.
If I could just add something on this. This is a question I've been wrestling with for the last 10, 15 years about building the capacity of public sectors in developing countries. It goes way beyond the health sphere. And I think that's ultimately the name of the game in development. The problem is that a lot of the big obstacles, especially in the really tough cases that you cited, yes, there's a lack of technical capacity, but fundamentally the problems are political, that you've got entrenched stakeholders that do not want the system to be different. And until you generate the kind of political power to push back against them, it kind of doesn't matter how many well-trained professionals you have. I mean, Syria has basically driven all of its trained professionals out of the country in the last 5 years. So that's one comment. The other thing is that in the international development community, they gave up on promoting elite education, more than a generation ago. And so the emphasis has really been on K through 12, universal K through 12. And I actually think that may need another rethink because, in fact, no country that's rich today actually ever started with universal K through 12. They started with elite education precisely because you need those, well-trained elites that are going to run the institutions, and then, it eventually spreads to the rest of the population. But if you start with the with the lower level education, you may not have the leadership. So.
Hi, my name is Dylan Bush from UC Berkeley and also on staff of the Central American Refugee Foundation here in Oakland. So my question is, and it's primarily about the American health diplomacy system, public health diplomacy, and global health diplomacy. So my question is kind of how can, and I first want to say that I recognize the importance of the work that's being done on the ground, but in a broader sense, is this idea of global health diplomacy not an attempt to treat, for instance, a heart attack with a Band-Aid? I mean, how can we advocate for global health gains internationally when our own broad economic and diplomatic policy oppresses underserved communities worldwide, like the Chevron spill in Brazil, or our funding of the civil war in Guatemala, which continues to cause public health issues there? And worse, could this not be used as a kind of PR tactic by our government to say, look at the work we're doing, look at the great work we're doing, but at the same time, those problems are created by our government and our diplomacy in itself?
I think you raise a number of legitimate concerns that I think are really important for them to be articulated and for you to convince yourself that there are mechanisms of visibility and transparency that allow you to hold your government accountable in the behavior that you're speaking to. The people who implement within your government come from a variety of different perspectives that are also checks on your concern. For it to unravel that much would be very hard in our system for people in the State Department, in the government, at multiple levels within the medical delivery system in country, to not call foul on what you're presenting. But could it be used in the way you say? It potentially could be. So I think it's a fair thing to have your antennae up with.
If I could add also on that point, PEPFAR probably would not have existed but for September 11th. And it was certainly used by the Bush administration, to soften its image in conducting a very unpopular war. On the other hand, it wouldn't have existed but for September 11th. And so, in a certain way, even if things are done for the wrong purposes, they can still have a beneficial effect. Please.
Hi, my name is Damiano Rondelli, University of Illinois at Chicago. My question is, what is or what should be the role of diplomacy or health diplomacy in situations where neighbor countries enter in a political crisis and the diplomats from these countries actually support the governments? My example is based on a recent experience in India and Nepal with healthcare damages, I think, from an embargo that actually caused Nepal to have a shortage of food, of supplies, of everything. And for the hospital that we've been working with, it's, to have limited ability to take care of the patients. So I guess could be, or the question is should there be a global health diplomacy that actually can intervene or collaborate with the diplomacy of each country in cases where legitimate or illegitimate oppositions may surge to preserve the projects and the programs and the healthcare of the patients there?
I think in many ways that's the vision of WHO in the role that it was originally conceived in, but has had difficulty realizing. I think you're describing a need, and if there were rational minds to be engaged in a constructive discussion around the medical needs that have been created by the conflict, it should be fully taken advantage of. But I think we have institutions that stutter in that ability to insert themselves in the way that you described, even though I don't think there'd be any argument that that is a real need. And I hope that our multilateral institutions can reform themselves to play the role that you've articulated, because we've seen that repeated over and over again, but it'd be a misconception to think that that capability is in place.
Okay, we only have 5 minutes left, so let's move through the remaining questions quickly.
Okay. Hi, my name is Nirja. I'm from India, but currently at Johns Hopkins. My question is, we touched a little bit about brain drain, but my question is, estimates put that 1/4 of physicians in places like the US are foreign trained, and I think they are in a very unique position where there can be bridges between their adopted countries and their countries of origin. Are there strategies in place where you can leverage diaspora members and health workers and train people in a way to build a soft diplomacy and global health diplomacy?
Do you want to take all the questions and we can answer?
Okay, let's do that. So let's just take all the remaining questions, and then panelists can answer maybe that's because no one has an answer to that question.
Yeah.
Go ahead.
Okay, I don't promise my question is going to be very easy either. It's a question I want to really ask you, get your insights on. So my name is Sulzan. I'm from Duke University and the Speak in Global Health. My question is, I thought the discussion really touched upon, the whole sovereignty issue on one end and the equity issue on the other. And obviously the greatest need in terms of global health is in areas where there is conflict, where there is weak governance, and a lot of donors are, obviously wary of going there because, obviously return on investment in terms of aid effectiveness is really low. Now, obviously, countries like China have been filling that gap where, you've been going, irrespective, you would respect the sovereignty, while countries such as Denmark or Norway, giving the Uganda example, cut back on aid, because of, obviously, certain laws that were implemented in the country. So that's one area, but on the other end, when countries like China go in, there is no incentive for that country, that particular country, to implement measures to improve governance. So where is the right balance, according to you? How do you achieve that? How do you achieve the right balance in ensuring there's equity in terms of development or improving global health outcomes, and at the same time improving governance in those areas?
Okay, good question. Let's have the last one.
Hi, Michael Chung, University of Washington. I'm interested in the term, in the title of power. how powerful is health as a diplomatic tool? Is it as soft as we think it is, or is it actually harder than we think it is? I'm kind of curious to hear what the panelists think. You know, from maybe the donor government side, have they looked at health and said, wow, you know what, this is as important as military spending in our armamentarium in diplomacy. We really need to have it. We ignored it before. Or how much is it on the other side where maybe recipient governments really don't care about the health of their people and so really don't care about what spending is done there, and therefore it's not really useful as a diplomatic tool?
Okay, the floor is open for any of the panelists to answer any of those questions.
So the chair can also answer questions, isn't it?
They can.
Yeah.
Well, it's all up to
Just
me.
suggesting.
Well, the only question that I feel like I have some purchase on was the middle one about what's the right balance between being intrusive and also trying to affect, you know, the governance of difficult places that don't meet a lot of global standards. And I guess what I have to say is, well, there's no, you know, it is a question of balance, and there is no single answer, and it really depends on the particular context of the country involved. And so I actually happen to think that that decision about Uganda, you know, because of the violation of LGBT rights, you know, basically threatening to cut off aid across the board, was a ridiculous decision. I mean, there just have to be some priorities in terms of, you know, the kinds of goals that the international community wants to make. On the other hand, I, more than a lot of people, am quite aware of the limits of the ability of international donors to actually improve governance on the ground. We've been beating our heads against this wall for some time, and sometimes, you know, there are cases where we can help. A lot of times we actually have made things worse. And so it's a very difficult issue that I think you've got to look at every single country and just kind of understand the political dynamics and what's possible to achieve, you know, before you can really address that question seriously. So
I'll take the diaspora question. You can have the last one. So just to say, before 1994 in South Africa, we had this iniquitous system of apartheid, and one of the ways in which the academic community reacted to that was to place academic sanctions. So not inviting South Africans to international conferences, and those of us who were in the progressive health movement also didn't go to international conferences unless they were going to advance our cause. So in that environment, there were two kinds of people who left the country. The one lot who were scared of change, and the other lot who left because of the military conscription. They left, they didn't want to serve in the army. And so while they were outside, they were supported by a number of institutions around the world to develop, to get new skills in different areas so that they could come back. Now, some of them haven't come back. In fact, I met one of them here yesterday. And those who have stayed outside have now continued to support the new South Africa. So I think that there is a way in which the diaspora can engage with outside institutions. It helps if there's a target, if there's a plan, if there's a way of thinking about it. One of our areas was public health, so we got lots of support from schools of public health in the US at that time. So I would encourage whoever is here, because you want to go back to your country, think about that. Benefit from the global environment for when you go back.
okay, well, with that, our time is up, so I'd like to thank the panelists very much for a wonderful discussion.